Hi Raju, how are you this morning? Do we have also this wonderful sunshine like here in Switzerland?
No, for us, it's just a very gray sky with terrible rains, with the whole city coming to a standstill. But the summer is visible on your face, obviously.
So
The,
we will go back to medicine then.
yes,
And this morning I had a meeting with our nephrologist. We always discuss our difficult cases in common. And today our colleagues presented a GIA case with hypertension. And it's interesting that the most common cases we follow, the GIA, usually are not a case for discussion with our nephrologist colleagues. And how is it on your side, Raju?
Michael, you won't believe it. But when I spoke to some of my friends in Europe, I told them that we still see systemic GI with amyloidosis. I recall a child with systemic GI. This child was lost to follow up for quite some time, and he walked in with anasarca. I asked my fellow to request a routine urine to look for nephrotic range proteinuria. She looked quite befuddled and wondered why I was asking for a urine in GI. And sure enough, within minutes, the pathology laboratory came back and said that the urine showed 4 plus proteinuria. A follow up biopsy confirmed amyloidosis. Other than in patients with systemic GIA, I do not regularly monitor urine or creatinine unless the child has received a very long duration of NSAIDs or peculiarly indomethacin, which in our country some adult rheumatologists continue to use. But do you regularly monitor urine and blood pressure in your GIS?
Yes, we do it regularly, but sometimes I ask myself if it's really useful and how often we need to do it. And so I came across of a paper recently from an Italian team on early signs of nephrologic involvement in GIA patients. And they compared 20 patients with GIA and 20 controls, and they measured blood pressure, calculated glomerular filtration rate, and performed urine analysis for proteinuria and hematuria.
So 20 patients and 20 controls, it's a small number, but I would at least start by imagining that they had no systemic GIS in their study.
You are right, there were no systemic GIA. And actually, they did not see a difference with the controls for the blood pressure. And they only reported higher values in GIA children for hematuria and proteinuria. But they did not see a difference between patients with high disease activity and low disease activity. But what is your personal experience with this, Raju?
None at all, Michael. As I told you, I have not been looking at these renal parameters. But I would definitely imagine that in their exclusion criteria, they would have excluded orthostatic proteinuria. But how did the authors explain these findings? What were their hypotheses?
So first, yes, they excluded patient with orthostatic proteinuria. The problem is that sometimes we see that only sometimes in the patient. So it's difficult to really be sure that all patients who sometimes will present orthostatic proteinuria are really excluded. But okay. And now for the reason for this proteinuria, it's probably multifactorial. And so autoantibodies, like in rheumatoid arthritis, were shown as involved, potentially involved, but in GIA, these rheumatoid factors are often negative, and the non-specific ENA are very low, and we don't have other specific autoantibodies that we know. And chronic systemic inflammation may also involve glomerular endothelium and induce glomerular disease. And also, you know that the drugs can also give this problem.
So I agree that the disease itself creating a chronic inflammation, like probably has been suspected in adults with rheumatoid arthritis.
And here the problem with JIA is that it's an exclusion diagnosis because we don't have rheumatoid factor like for adults. And so it's also possible that with the time, the patient we diagnose with GIA will show another disease, connective tissue disease. And this is something what some of my adult rheumatologist colleagues, where we do transition clinic together, have reported in a few cases of our patients.
Tell me, Michael, these patients in whom they saw hematuria or proteinuria, did they follow up with a kidney biopsy?
No, they did not, and this would have been very interesting. But they said that they would do it in the next phase or as a separate study.
That would indeed be good, but you've given me some food for thought, and I will start occasionally looking for the urine of our JIA patients. Only thing is that if I do find this happening, I will write to you to ask you what to do with them. But what are the values of proteinuria that they have indicated in the paper?
Yes, this is a good question because the values they report are very low. So it's not massive proteinuria like we see in renal involvement in lupus. And some of the values are really overlapping with the values found in controls. So it's difficult to know what is really the cutoff we need to have to go further with something else in our clinic. Because the highest value were between 100 and 150 milligram per square meter per 24 hours. And again, we should not forget that sometimes we have patients with orthostatic proteinuria. And so when we see that, we often check early morning urine. And I should say that often the low level proteinuria in my patient is just disappearing. So I would not investigate further, except if there are other alerting signs or perhaps higher levels. And there is the value of measuring these things. If we have positive results, then we have to check back to the patient and see if there are any sign of other connective tissue disease.
Okay, I will buy the proteinuria part, but the hematuria will still, bother me a little bit. But why are the findings of this paper useful to us as pediatric rheumatologists?
I think your comment about hematuria is important, especially because we have more girls than boys. And when you look at teenager, then you could have hematuria just because it's a monthly period of these young ladies. So we have to be also careful to not overinterpret something which is likely to be normal. And so proteinuria and hematuria reported in this paper, we could imagine it could signify the beginning of a renal damage that may further develop into adult age. But our problem as pediatricians is that we don't follow our patient for 30 or 40 years. We lose them after the transition clinic, so at 18 or 20 years. So we don't know what is happening during the third or the fourth decade, and there might be some problem that we could prevent, and in particular this renal problem that we could prevent during pediatric age.
True, a stitch in time would definitely save nine. So we have two options I would take. One, that this Italian group follows up a larger cohort and does kidney biopsies in them, or you have the adult cohort who are carrying their disease from childhood and you study them cross sectionally for their renal function. I do hope that you would agree with me on this, Michael.
This is absolutely true, and this would be a very important point for us as pediatric rheumatologists. But now I go back to the start. So I'm lucky today with the sun. So I think I will go to the lake. And I'm sorry that I let you with your rain today. So it was a pleasure. Goodbye, Raju.
Bye.